It's 2 a.m. in the morning, and you are the only doctor in the casualty. A 50-year-old man walks in. He's sweaty, pale, and he's clutching his chest because of pain. You did everything right. You send an ECG, there is no ST elevation. You send a tropi is negative. You relax for some time, you go for a break, you come back. After 4 hours, the same patient comes back. Massive anterior wall MI. So what really went wrong? What did you miss? Is the STEMI and STEMI criteria outdated? Do you know about the OMI versus NOMI criteria? Let's go. In this video, we are ditching the STEMI versus NSTEMI criteria for the game-changing OMI versus NOMI criteria. And by the end of this video, you will spot acute LED occlusions even before the ST segment elevates, and you are going to save lives. Let's dive in. Why is the old STEMI versus NSTEMI criteria failing us hard? What do you notice when you get an ECG of a patient for the first time? ST segment, right? Because we were taught like that. But infarction can also affect depolarization as well as repolarization. So QRS complex, the ST segment and T waves are equally important. So that's where the STEMI and STEMI criteria is way too rigid. It cannot accommodate all these dynamic changes. There comes our hero, the OMI versus NOMI criteria. Meet OMI, the occlusion myocardial infarction, proposed by Dr. Smith. Yes, you might know him from the Smith-modified Scarbosa criteria for the new onset LBBB in the year 2018. Dr. Smith is an ECG wizard, and this video is totally based on his teachings. Now, let me show you some proof. In the year 2017, a meta-analysis by Khan et al. Showed that 40,000 people who were initially diagnosed with NSTEMI were later taken to cath lab after 24 hours. Out of this, 1/4, that is 25% of these patients had total LED occlusion, which is a huge number. And all of these patients had higher biomarkers, worse left ventricular function, and higher mortality. And sadly, many of them were young and healthy individuals. Imagine the amount of myocardium that would have been saved. There are literature from the year 2001 which supports this. Let me show you an ECG of a 37-year-old female who walked into the casualty with complaints of chest pain. So initially an ECG was sent, and parallelly a tropi was also sent. Tropi came negative, and the ECG did not show any acute ST elevation, and the patient was sent to her home. Sadly, she passed away after 4 hours. What we really missed in this ECG? So this is where the OMI-NOMI really becomes a game changer or the lifesaver. So in this ECG, you could clearly see that the T waves are towering over the preceding QRS complexes in both V2 and V3. And the area under the T wave is quite large, which is abnormal in this ECG. These two will be enough to predict that this is an occlusion myocardial infarction. This patient could have been saved. We might have also heard something called as STEMI equivalence. The word STEMI equivalence only is the proof that STEMI does not catch everything which are essential. So, as you can see, when there is an acute coronary occlusion, the initial minutes to hours, there will be development of hyperacute T waves. And the judgment whether this is hyperacute T waves or not is purely based on proportionality, not by measurement of only T waves. So the T wave should always be compared with the preceding QRS complex. And it need not be always tall. You should always be checking the area under the T wave as well. Following by which there will be ST elevation and a Q wave which is developing over 1 to 12 hours. After which the ECG will show ST elevation with T wave inversion, and within weeks to months there will be a T wave recovery. So the OMI-NOMI criteria is not a guesswork. It's not a checklist either. It's a pure pattern recognition grounded in physiology. And I'll teach you how to do that in the upcoming videos. So follow for more and save some myocardium, save lives.